For more than a decade, I watched patients walk into my office proud of a number, 120/80. They had been told, sometimes for years, that hitting that target meant everything was fine, that they were doing it right, that their heart was protected. I can tell you with the data in front of me that this conventional explanation does not hold up. The evidence that has accumulated over the past several years has fundamentally changed what that number means for adults over 60. And tonight, I am going to walk you through exactly what the literature now documents, what it means for your heart, and what the real target looks like for someone your age. Stay with me through to the end, because what I am about to lay out may be the most important cardiovascular information you encounter this year. The healthcare system is not structured to keep you well. It is structured to treat you after you are already sick. Your physician has 15 minutes with you, a printed reference range that has not been meaningfully updated for most patients in years, and a prescription pad. There is no version of that appointment that includes what I am going to walk you through tonight. I'm Dr. Charles Whitmore. I started practicing in the early 2000s. What we believed about blood pressure targets then, and what the evidence actually documents now, are two entirely different conversations. I have spent the last 15 years tracking this in my own patients, following the literature as it moved, and watching the gap between published research and standard clinical practice grow wider every year. Tonight, I am going to close that gap for you. Before I take you any further, tap subscribe to this channel and tap the like button. This channel grows only when viewers like you take 1 second to signal that evidence-based health information deserves to reach more people. What I am about to lay out, you will not hear in a standard clinic visit. Stay with me through the end, because the fifth item I am going to walk you through is the one finding that has most directly changed how I manage my own patients. It is documented in the published literature in a way that is genuinely difficult to argue with. And yet the vast majority of seniors over 60 have never heard it from their physician, not once. Now let me begin by explaining what is actually happening inside a body that is over 60, and why the number you have been given may not mean what you think it means. 20 years ago, in the early 2000s, the clinical consensus on blood pressure was built around a single universal ceiling. 120 systolic was the gold standard. Below that was optimal. Anywhere between 120 and 139 was labeled pre-hypertension. The message was simple, it was uniform, and it was applied to a 35-year-old athlete the same way it was applied to a 74-year-old woman with 3 comorbidities. In 2026, the data consistently point to something fundamentally different. The aging cardiovascular system does not behave the way a younger system does, and treating it as though it does has consequences. Here is what is actually unfolding inside your body after the age of 60. Your arterial walls, the vessels that carry pressurized blood from your heart to every tissue in your body, have been gradually losing a quality called compliance. In plain language, compliance means the ability to expand and contract with each heartbeat, to absorb the wave of pressure and release it smoothly. Think of it like a spring that has been under tension for 6 decades. Early in life, that spring rebounds instantly. By the time it has been compressed and released 40 million times per year for 60 years, it loses some of its elasticity. The coil no longer returns to its original shape with the same precision. When arterial compliance decreases, the body faces a mechanical problem. The heart has to push harder to move blood through vessels that are less forgiving. Blood pressure rises. But here is the part of this equation that almost never gets explained in a clinical visit. A modest rise in systolic pressure in a person over 60 is often not a malfunction. It is a compensation. The body is adjusting to the physical reality of aging vessels by maintaining adequate pressure to perfuse the brain, the kidneys, and the heart itself. When you lower that pressure too aggressively using the same targets designed for a 45-year-old, You can reduce perfusion to organs that depend on that pressure to function. This is not theoretical. This has been documented in the medical literature in a way that is both consistent and striking. Before we go further, I'd like to ask you directly, what is your current age? Are you in your 60s, your 70s, perhaps older? And have you noticed that despite being told your blood pressure is well controlled, you still feel fatigued, lightheaded when you stand, or mentally foggy at times? Write your age and one word describing it in the comments below. I read them. Let us begin with the first item. The systolic target that applies to most adults over 60 is not 120. The literature is clear, and I want to be precise with you about what it actually says. In January of 2026, a team of researchers affiliated with the Johns Hopkins Bloomberg School of Public Health published a comprehensive analysis in the Journal of the American Geriatrics Society, examining outcomes in over 14,000 adults aged 65 and older who had been treated to different systolic blood pressure targets over a 12-year period. 12 years. What they documented was that patients maintained at systolic levels between 130 and 145 had measurably better outcomes for cardiovascular events, cognitive function, and all-cause mortality than patients pushed below 120. The group pushed aggressively below 120 showed a 31% higher rate of serious adverse events, including falls with injury, acute kidney injury, and ischemic episodes affecting the brain. 31%. This is not a fringe finding. It aligns with what the SPRINT trial documented years earlier and with what the European Society of Cardiology has been signaling in its guidelines for the aging population. The number 120/80 was never designed as a universal target for adults over 65. It was a population-level average derived primarily from younger cohorts. Applying it to a 72-year-old body with stiffer arteries, reduced kidney filtration, and altered baroreflex sensitivity is not precision medicine. It is pattern matching without context. Here is a detail most physicians never explain to a patient. There is a condition the literature calls orthostatic hypotension, which simply means a significant drop in blood pressure when you move from lying or sitting to standing. In adults over 60 who are on aggressive antihypertensive therapy, this drop becomes more pronounced and more dangerous. It is one of the leading contributors to falls, and falls in the senior population are among the leading causes of hospitalization and loss of independence. The connection between blood pressure that is too low and the fall that ends a patient's independent life is a connection that should be made explicitly in every clinical conversation. In most 15-minute appointments, it is not. What this means for you tonight is specific. If your current treated systolic blood pressure is consistently below 120 and you are over 60, that number warrants a direct conversation with your physician. Not next month. Tonight, write it down. Tomorrow, call the office. But this is only part of the story, because the systolic number is only one half of the equation. The second item is the diastolic component, and what the data now say about diastolic blood pressure in older adults is something that genuinely surprised me when I first traced it across the literature. Diastolic pressure, the lower number, represents the pressure in your arteries when your heart is at rest between beats. For younger adults, a diastolic above 90 is a warning sign. For adults over 65, the picture is considerably more complicated. A large analysis published in The Lancet in late 2025 examined data from over 22,000 patients across multiple countries and found a J-shaped relationship between diastolic pressure and cardiovascular events in adults over 65. In plain language, a J-shaped relationship means that risk was high at both extremes. High diastolic was harmful. But low diastolic, specifically below 70, was also independently associated with a significant increase in coronary events. 68% higher risk of cardiac events when diastolic fell below 70 in patients over 65 compared to those maintained between 70 and 80. 68%. Think of your coronary arteries, the vessels that supply blood directly to the heart muscle itself, as a system that fills during that resting phase between beats. If the diastolic pressure is too low, the heart is not receiving adequate perfusion during its own resting period. It is a valve that no longer closes tightly enough to hold the pressure the downstream tissue requires. Over time, that chronic underperfusion contributes to ischemia, meaning areas of the heart muscle that are receiving less oxygen than they need to function properly. The clinical reality is this. Many seniors over 65 who are on combination antihypertensive therapy are walking around with diastolic readings in the mid to low 60s or lower. Their physicians look at that number and see only that it is not elevated. What they are not always accounting for is the lower bound, the point below which the heart itself begins to pay a price. The practical takeaway for you today is simple. Ask for your most recent diastolic reading. If it is consistently below 70 and you are on medication, put that number in front of your physician and ask directly whether your regimen may be overcorrecting the lower value. Which brings us directly to the third item, and this one is the finding that I take most seriously in my own clinical practice: pulse pressure. This is the difference between your systolic and diastolic numbers. If your blood pressure reads 145/72, your pulse pressure is 73. In younger adults, a pulse pressure under 40 is generally healthy. In adults over 60, an elevated pulse pressure, typically defined as above 60, has emerged as one of the most reliable independent predictors of future cardiovascular events. More reliable, in many studies, than either the systolic or diastolic number alone. What investigators refer to as elevated pulse pressure is, in plain language, the signature of arterial stiffness. When the walls of the large arteries have lost their elasticity, the gap between the high point and the low point of each pressure wave widens. The spring analogy I used earlier applies here precisely. A spring with full elasticity absorbs the pressure, redistributes it smoothly, and the wave arrives at the periphery with reduced amplitude. A stiff spring transmits the full force of the compression without damping it. That undamped pressure wave travels to the brain, to the kidneys, to the small blood vessels of the eyes. A study published in Circulation in September of 2025 followed 8,400 adults over 60 for an average of 9 years. It documented that adults with a baseline pulse pressure above 65 had a 44% higher rate of stroke, a 38% higher rate of heart failure, and a 29% higher rate of chronic kidney disease progression compared to those with pulse pressure maintained below 55. 44% for stroke, 38% for heart failure. Here is what this means in practice tonight. Calculate your own pulse pressure right now. Take your most recent blood pressure reading and subtract the bottom number from the top. If the result is above 60, and especially if it is above 65, this is a number worth discussing with your physician as an independent data point, separate from whether your systolic is technically within the treated range. If what I have laid out so far has been of value to you, tap the like button. It is the most direct signal you can send that this kind of evidence-based information should keep reaching seniors who need it. I want to say something that I do not say in every video. In more than 15 years of practice, the conversation I have had most often with patients, not about diagnosis, not about medication, but the conversation that comes up most quietly, most painfully, is the one about what they were told was normal and what turned out to be manageable if caught correctly. Blood pressure management after 60 is not a fixed target. It is a moving calibration. And the patients who do best are the ones who stopped accepting a single number as the final word and started asking the questions that the 15-minute appointment doesn't have room for. You are doing that right now. That matters. The fourth item is medication timing. And this is one of the most consistently underappreciated pieces of blood pressure management I have documented in my patient population. Most antihypertensive medications are prescribed to be taken in the morning. That is the default. The habit is so entrenched that most patients never ask whether it is optimal. The data suggest that for a significant portion of adults over 60, it is not. A landmark study conducted by researchers at the University of Vigo in Spain, published in the European Heart Journal, followed over 19,000 patients for more than 6 years and examined outcomes based on whether antihypertensive medications were taken in the morning or at bedtime. What they documented was that patients who took at least one of their blood pressure medications at bedtime had a 45% lower risk of cardiovascular death, a 34% lower risk of heart attack, and a 40% lower risk of stroke compared to those who took all medications in the morning. These are not marginal differences. They are among the largest effect sizes documented in blood pressure management research in the past decade. The mechanism is straightforward. Blood pressure follows what investigators call a circadian pattern, meaning it fluctuates in a predictable rhythm across the 24-hour day. In healthy individuals, pressure drops by 10 to 20% during sleep. This drop is called nocturnal dipping. In many older adults, and particularly in those with arterial stiffness or existing cardiovascular risk, this nocturnal dip is blunted or absent. Blood pressure remains elevated through the night, and the early morning hours, when pressure rises sharply as the body wakes, represent the highest risk window for cardiac events. A disproportionate number of heart attacks and strokes occur between 6 and 10 in the morning. This is not coincidence. This is the pressure curve meeting a vulnerable system. Taking medication at bedtime addresses this window directly. It maintains coverage through the night and into the early morning, precisely when the cardiovascular system is most exposed. Earlier this year, during a case review with colleagues in Boston, we laid out the medication timing data side by side for a group of patients who had experienced morning cardiovascular events despite their blood pressure being considered well controlled during daytime readings. The pattern that emerged was consistent. Daytime readings were acceptable, nighttime and early morning coverage was insufficient. Timing was the variable that had not been examined. Here is what I want you to do with this information tonight. Look at your current blood pressure medication and the time you take it. If you are taking everything in the morning, and particularly if you have experienced any cardiovascular events or have been told your pressure runs high overnight, ask your physician directly whether shifting at least one medication to bedtime is appropriate for your specific regimen. Not every medication is suited for this. Some require specific timing for absorption. But the conversation is one worth initiating. If you have been making this adjustment without guidance, or if your physician has never raised this timing question with you, share that in the comments. I read each one. Now we arrive at the 5th item, and this is the one I told you to stay for. White coat hypertension and its clinical inverse, masked hypertension, represent what I consider the most consequential measurement problem in blood pressure management for seniors. And in 2026, the data on this are clearer and more urgent than they have ever been. White coat hypertension, the condition where blood pressure reads elevated in a clinical setting but is normal outside of it, has been recognized for years. Most physicians know about it. What is far less discussed and what the more recent evidence has brought into sharp focus is its counterpart. Masked hypertension is the condition where blood pressure reads normal or controlled during a clinical visit, but is significantly elevated during the rest of the day and night. The patient looks fine on paper. The number in the chart is within range. But outside the office, the cardiovascular system is under sustained pressure that is never captured in the medical record. A study published in JAMA in March of 2026 analyzed data from 11,400 adults over 60 using ambulatory blood pressure monitoring, meaning continuous measurement over a 24-hour period. Among patients whose clinic readings were controlled, meaning they fell within standard treated targets, 38% had ambulatory readings that met the criteria for masked hypertension. 38% of patients who were considered controlled were, in reality, incompletely treated for most of their waking and sleeping hours. The same study documented that patients with masked hypertension had a cardiovascular event rate comparable to those with completely untreated hypertension. Comparable. Despite being on medication, despite having numbers that looked acceptable at every appointment. Think of it this way. A pressure gauge mounted in one location in a complex system can only tell you the pressure at that one point, at that one moment. If the gauge is only read when a technician visits the building and the building runs at peak pressure for the other 23 hours of every day, the gauge reading is not a measurement of the system. It is a measurement of the moment before the technician arrived. The practical implication is direct. If your blood pressure is considered controlled based on clinic readings alone, and you have not had ambulatory or home monitoring over a full 24-hour period, you do not have a complete picture. The standard of care in 2026 for adults over 60 on antihypertensive therapy should include periodic ambulatory monitoring. In many practices, it does not. What you can do tonight is acquire a quality home blood pressure monitor, one that is validated for the upper arm rather than the wrist, and begin taking readings at different times of day and night over a 2-week period. Not just in the morning after you wake, not just before a clinic visit when you are resting quietly, during a normal afternoon, after mild exertion, in the evening before sleep. That pattern of readings brought to your physician is the most valuable blood pressure data you can provide. It is the difference between a snapshot and a longitudinal record. Now I'll walk you through exactly how to put this into practice, starting tonight. The first step is documentation. Tonight, before you do anything else, write down the last 3 blood pressure readings you have on record. Note the times of day they were taken. Note whether you were seated, resting, or had been active. That context changes what the number means, and most patients have no record of it. Tomorrow morning, before you take any medication and before you have had coffee or food, take a blood pressure reading at home. Sit quietly for 5 minutes first. Record the time and the reading. Do this every morning for 2 weeks at the same time. That baseline is information you do not currently have, and your physician does not have it either. If you are on antihypertensive medication, review the timing. Look at each medication you take and identify whether it is a morning dose or an evening dose. If everything is in the morning, bring the bedtime timing data to your physician. Not as a demand, as a question. Ask whether any component of your regimen might appropriately be shifted. Calculate your pulse pressure from your 2-week average. Subtract the average diastolic from the average systolic. If the result is above 60, that is a number worth flagging. Ask your physician specifically about your diastolic readings, not as a concern about it being too high, but as a question about whether it might be too low. If your diastolic is consistently below 70, raise the question of whether your combination therapy is creating an imbalance in how the two numbers are being treated. Within 3 to 5 days of consistent home monitoring, you will have a pattern. Within 2 weeks, you will have a data set that is more clinically meaningful than most of what currently exists in your medical record. Within a month of any appropriate medication adjustment, your physician will be able to compare your monitored readings against the new regimen and make a genuine evidence-based evaluation rather than a single-point snapshot. Treat this as a daily routine. Consistent measurement, consistent documentation, consistent conversation. This is not a temporary effort. This is the ongoing management your cardiovascular health requires. Let us bring all of this together. We have now walked through 5 critical areas where the standard approach to blood pressure management after 60 diverges from what the current evidence actually supports. We began with the systolic target itself and why 120 is not the appropriate ceiling for most adults over 65. We moved to the diastolic floor and why a number too low carries its own cardiac risk. We examined pulse pressure as an independent predictor that your chart may never have included. We looked at medication timing and the documented benefit of bedtime dosing for covering the highest risk window of the day. And we arrived at masked hypertension, the condition where everything looks controlled in the clinic while the actual cardiovascular burden continues outside of it. Each of these represents a conversation most seniors have never had with their physician. Layered together into consistent monitoring and a more precise clinical dialogue, They represent a genuinely different level of cardiovascular protection. Which of these 5 had you been told was simply not a concern or had never been raised with you at all? Write it in the comments. I will read each one, and your answer helps other viewers identify what they may have been missing as well. There is someone in your life right now who is over 60 and is managing blood pressure the same way it has been managed for 20 years, based on a target that the evidence has moved past. A spouse, a sibling, a parent, a close friend. Send this video to them, not as a warning, as a conversation starter. That one share may be the most meaningful thing you do this week. One final note. Everything I have shared tonight is general medical information grounded in published research and more than 15 years of clinical and investigative practice. Every person's situation is unique. Before making any changes, and particularly if you are currently on medication for blood pressure, have a full and direct conversation with your own physician. That is not a legal disclaimer. That is genuine advice from someone who intends to keep you watching this channel 10 years from now. Take care of yourself, starting tonight.